So let me go ahead and share my screen with you here, and we're going to start with the lecture. All right, hopefully everybody can see this. Yes. And again, we're going to start. Okay. Let me get this out of here so I can see my screen. All righty. So again, we've already went over the topics of who I am and what I'm doing. The one thing that I like about the elbow is it can be compartmentalized. The elbow itself can be brought into regional anatomy from the anterior area, lateral area, medial compartment, and the posterior compartment. Now, with that being said, we know that some of these scans that we're doing, it's all or nothing, such as the shoulder, which we've done scans on. When you do the shoulder, you pretty much do the whole shoulder. In the elbow, we can break it down a little bit easier into 4 regions. With that being said, I have simplified this into 8 of the more common structures that we see in the elbow itself. Now, like I said, there's a lot more that we can see with ultrasound. There's a lot more that we see in our clinic here, but for what we want to do here and the simplicity of this is I want to bring you the most common. So the 8 most common are going to be the anterior elbow cross section. That's one of the big foundations of what we're going to look at with most of your elbow scans. It's kind of the base point for a lot of the pathology that we can see in the elbow. From that point, we can move to all sorts of directions. The radial nerve, so the superficial radial nerve and the PIN, so the posterior interosseous branch right along the radial head. We're also looking at the distal bicep tendon. The distal bicep tendon can get very complex. There's 4 windows within itself to look at the distal bicep. When we get into that, I'll explain that a little bit more. The common extensor tendon, again, out here in Arizona, everybody loves to golf. So we do see quite a bit of that common extensor tendon or that lateral epicondyle out here. The radial collateral ligament, which is right adjacent to that common extensor tendon. We usually take a close look at that when we're doing the lateral elbow as well. And the common flexor tendon, which is on the medial side. So that's the real golfer's elbow. And then, like I said, the common extensor, some people call it the tennis elbow. Common flexor, some people call that the golfer's elbow. And then we have the ulnar collateral ligament, which some people know as getting the Tommy John or having that compartment. And then the triceps, which is down there. So let's go into the anterior structure here. So you can see in this picture, the probe is in what they call short access to the humerus. Okay, so the shaft of the humerus coming down in this direction here, the orientation of the probe is short axis, or what they would call like an axial view. This is our starting point for looking at the anterior elbow. When we look at this, we can break it down almost into what looks like a triangular shape, and we can put our anatomy into these regions to help kind of break it down and make it easier for us to understand what we're looking at. When looking at the triangle, let's look at the apex here. So starting with the biceps brachii, the muscle tendinous junction and the tendon are going to be up at the top. Looking down to the lower right-hand side of the screen, on the medial side, we're going to see the pronator teres. Okay, moving along that again over to the lateral side, we'll see the brachioradialis. So those are the 3 tendons that comprise the triangle there, and right in the middle of that is the brachialis muscle. Just adjacent and outside the triangle, we can see on the lateral side the radial nerve, and on the medial side, we can see the brachial artery and the median nerve. So this depiction is a good way to kind of get yourself referenced on how to look at the anterior elbow to start yourself out. So here's another picture, but this is the ultrasound view. So this is this ultrasound view now turned into the picture on the screen. So once again, what we have at the top of the apex of the triangle is that biceps tendon. Working our way down is the pronator teres and the brachioradialis, which comprises this whole region here. Right outside of that, we have the radial nerve, the brachial artery and median nerve combined here, and right in the middle is the brachialis, the big brachialis. Now, this level here you can see the probe is distal in the humerus right before the joint line. You'll know you're at the joint line when you look at your screen and you see this wave down at the bottom. That space right there is the distal humerus. That is going to be the joint line, and you can see this dark line above it. That's going to be your hyaline cartilage. So this is the joint space right here. Now, I have a couple videos from Colin Rigney. We work together as a team in our company at Modern Physical Therapy and at Advanced MSK Ultrasound Center. So we got together and we did a lot of these videos here. So first things to note is if you can see my pointer, you can see Colin sitting here with the patient, with our subject here. The patient is laying supine on the back here, and the arm is at a neutral position with the hand and the elbow into a supinated position. That opens up that space. So let me fast forward here so you can see, as he's scanning in here, you can see his probe down here is going from proximal to distal down into that joint space. Once we get down into that space, you'll see that hyaline cartilage come in, and you know you're at the right area. Let me clean that up for you. And you can see right in here, there's that hyaline cartilage. That's our base of the distal humerus right here. And then you can see the cursor here. First thing you note is that big brachial artery up at the top. That's right outside our triangle. Then we move ourselves right over to this region here, which is that big median nerve. They go together in tandem, so they follow each other down the arm here. So if you know that you can find this big arterial space right here, you know that median nerve is not too far away. As we work over to here, you can see the big pronator. This is the pronator teres group right into here. And then as we work our way down to that big muscle group down at the bottom, that's the brachialis. Okay, so we're just following that triangle here. And then working over here, we see that bicep tendon. And if you look carefully at this level, and I'm going to move my cursor on top of this one here, you can see the biceps brachii tendon and a little bit of the muscle right around it. So this is at the point to where you're at that myotendinous junction, or at least you're at the point to where that muscle is turning into tendon. So it might look a little dark into here, but that's because it's transitioning from the muscular fibers into a tendinous fiber. And then, of course, on that other side over here, your brachioradialis on the lateral aspect here, and your radial nerve is nestled right inside there. And I tell you, when you start doing these repetitively, it gets easier and easier over time. The anterior elbow, out of all the structures, is probably the most complex. There's the most anatomy, there's the most neurovascular structures in there. There's a lot going on in the anterior elbow, and that's why repetition is key. So let's look at that radial nerve, and this is at the proximal humerus. This is at the distal humerus right here. I need to change that here. So this is at the distal humerus in short axis. At this area, the nerve will be more circumferential, meaning it's going to be more round. And if you've ever taken any type of anatomy for ultrasound, we know that nerves typically have a honeycomb, or what they call a bundle of grapes appearance. So it's very easy to see this type of structure when it's nestled between these muscle fibers through here. Another thing to note is when you're looking for a nerve, it's harder to find a nerve in long axis because it can mimic some of the connective tissues such as tendons, ligamentous structures, connective fibers in between the fascicles of the muscles. So a lot of times it's easier to see a nerve in short axis. So here we have a video of that distal, the distal humerus right before the radial head. And what you can see here is that nerve, again, circumferential, it's circular at this point in time. And at this point, you're seeing some of the brachialis at this, and then the brachioradialis over here. So it's nestled right in between here as it crosses over to the joint. Right in there. And so you can see where Colin is on the video down here. You can see it's at that distal humerus in short axis, right before the joint line of that ulnar radial space right here. So once again, it's right here. And let's move on to the next one, which will be at the joint line. So when we get into here, you can see down at the screen here, We're just at the joint line, so right at that humeral radial joint line, the humeral ulnar joint line. And you look at the nerve now, and you can see it's starting to flatten out a little bit, starting to change a little bit of the shape, and you can start to see some of the musculature around it changing as well as we go through. So the brachioradialis and that brachialis itself is starting to disappear at this distal level. As we go a little further down, what you're going to see is you're going to start seeing this flattening of the nerve, and this is where it's going to start bifurcating or starting to turn into the two levels at the supinator heads of the PIN, posterior interosseous nerve, and your superficial radial nerve. So you see down into here, as Colin goes a little bit more distal, we'll have a clear image of that space. Okay, so let's move down here. So here we go. And this is where the split occurs. So looking at Colin's picture right through here, what we can see is as he goes distal and comes down through here, you see the nerve bifurcating into two separate entities. Okay, remembering that the sensory nerve is going to be more superficial, and the motor nerve is going to dive a little bit deeper under that supinator head. And right here, you can see that supinator clearly right across the humerus, and as the nerve bifurcates down into this region. When we scan these in the clinic, what I've noticed is it's easy to find them on short axis. It's much easier to identify on short axis, but when you find it, rotate the probe 90 degrees and actually look at the fork or the bifurcation of the PIN, posterior interosseous, to the superficial radial nerve. And what you'll see is the two heads of the supinator clearly, and that's a good place to test for supinator syndrome or any type of entrapment of the nerve there. Let's go on down to the next picture, and I'll show you what I mean. So in this one, what we've done is we've taken the orientation of the probe, and we've gone from a short axis of the humerus to a long axis of the humerus and the radius. What you're going to see first is the radial shaft. So here's the shaft of the radius right down in here. As we go from, so we're going to talk from left to right. So from left side is going to be proximal to the right side, which is going to be distal. We're going to look at the shaft of the humerus here as it rolls up into that annular recess to the radial head. Let's take a look. There we go, right in here. So as you can see, the shaft of the radius coming up, you can see it's starting to turn upward. It's going to turn into the radial head of this annular recess. And now what you see is this band coming across. This is the more common area of that radial nerve. And you can see right here, you have this superficial band, and then you have this deep band right here. This is your posterior interosseous. This is your superficial. This is the two heads of the supinator that this kind of goes right in between. Upon inspection of pronation and supination, either actively or passively or with resisted supination, you can possibly see some constricted motion or some squeezing down and causing some entrapment into that nerve right into here. As you can see, there's those two layers right in there. So at this point, what we want to look at is while the probe is in this direction, you just take that ultrasound probe in the short axis of the radius, and we're going to find the radial head and the annular ligament that is right on top of it. So looking at this picture here, so this would be where your probe orientation is, and on the screen, it'll look like this here. So here's the dome or the top of that radial head, and this small fibrous texture on top that actually goes like a rainbow over it and will connect over through here. This is your annular ligament, and this can get disrupted with certain activities, traumatic events or repetitive motion trauma. One thing I tell people, especially the students and the people studying for their RMSK, is don't neglect the annular ligament. You'd be surprised what kind of things overlap and have issues in this area. Now, this is what I was talking about when talking about the biceps brachii. The biceps brachii itself has 4 windows. Does that mean that any 4 are superior to the others? Well, it really depends on what you're looking for and what your intention is. If your intent is to find the proximal, or the distal 2/3 of the tendon, if you're looking for the enthesis or the attachment side of it, or if you're looking for an injection side of it, it's going to depend on what window you want to look at. So let's start with the first one, which is the anterior window, which is what we started with before. So when looking at this picture here, you can see Colin is down here on the proximal radius, just distal to the humerus, just distal to the joint line. So if everybody can see my cursor, my arrow over here, you can see that the probe is in long axis to the radius, and it's in long axis to the humeral shaft here. Now, when looking over to the screen here, what you'll see is the radial tuberosity. That's the most distal end of the biceps brachii here. Now, what you'll see is these fibrous patterns here, almost like guitar strings of the tendon as they come down and attach to that enthesis. So as it attaches here, this is what we're inspecting, and we're inspecting that whole area. And typically, if you have tendinopathy or pathology in this area, it's going to be 1 to 2 centimeters proximal to that actual enthesis. You may see some cortical irregularities or some small fraying in this area, but most of your pathology is usually right in here. And what you also notice is the brachial artery. You can see the artery that kind of hangs out adjacent to it. So this is one of those things, if you're looking at this from an interventional point of view, there's a lot of landmines in this area. There's a lot of obstacles for this space. If you're looking for a bursa distension, this is a good area for it. I have seen some doctors drain this area, and I've seen some doctors have great success into injecting this area, but most doctors don't go to this area for interventional purposes. Now, moving on is the medial window of the distal biceps. With this one, arm placement is going to be, so a patient can be either supine or sideline. I usually put them in sideline. It's a little bit more comfortable. You can see here, this can put a little stress on the UCL and maybe a little stress on the shoulder. So if you have them sideline, which I'll show you with Tim during the live scan, is you have them sideline, it's a little bit easier to see this acoustic window. But you can see, once again, your probe orientation should actually be in line with the bicep tendon. This is where a lot of people get confused on how to scan for the distal bicep. So even though you've passed the humeral space, some people tend to follow the radial shaft, when in fact it's perpendicular to the radius at this level, and you just follow that humerus and that biceps down. And if you just follow that straight down, all the way down to the radius down here, you should find it on the medial side. And I'll show you right here. So this is a picture of it here. And I think what you see is the arrow showing the tendinous space, the radial tuberosity, and it looks very similar to the anterior acoustic window. There's that radial tuberosity. And then look at this, we have that medial, here's that pronator window, that medial side. Once again, you see Colin right through here, and his probe, once again, is following straight down in line with that humeral shaft. It's following in line with the biceps. If you keep that in mind, that's a good clinical pearl that you don't get lost. So if you find your bicep up in here, you bend that elbow to about 90 degrees, and you just bring that probe straight down in line with the humerus, you'll have much more success in finding that space. So let's take a look here. Now you can see on the video, Colin is doing a little pronation and supination of the wrist to make sure that we are truly seeing that radius rotate and this tendon being tethered and pulled back and forth. It's also a good test to see if there's any partial tears or any disruption to the fibers themselves. But mostly it's important to see if you're on the right structure. I had a doctor tell me one time, well, if there's 4 windows, are any of the windows good? Well, that's a good question. They're all good for different reasons. So once again, be sure to pronate and supinate that wrist here. Now, once we go to that lateral aspect, this is going to be the lateral acoustic window. And this is another good one because you're going to see more of that radial head. Again, key concept, making sure that that probe is in line with the bicep along that humeral shaft. And you can see as the probe comes down through here, the radius is actually going to be in short axis. So if you look over here on the screen, that's the radius right there. This is the supinators right on top here. And then if we look carefully, we have the brachial radialis. And deep here, this is the biceps brachii coming across this plane right here. Now, the cool thing about this is that this tendon is going to actually wrap up and under and come back over to this side here, which we're going to look at a posterior acoustic view here in a little bit. But right here, this is a great window to see that proximal or the proximal middle, or I should say the middle 1/3 of that tendon right in here. So you're not going to see the distal end. You'll see that middle 1/3 to be corrected there. So, and you'll see here, it's also important to pronate and supinate that wrist right in here. So you can see the radius moving back and forth and the supinators gliding over on top. And you can see that tendon moving back and forth like a seesaw being tethered right through here. Again, test it for integrity of the tendon and test it to make sure it truly is the bicep tendon. Now the distal approach. The thing with the distal approach is you're only going to see the very enthesis, or the parrot's beak, the very distal end of the bicep. Now, why is that good? Well, one, it's the enthesis, the attachment side. There could be some cortical irregularities. There could be some fraying at this area here, which could be telltale to some maybe some trauma or chronic repetitive injuries in the tendon itself. And a lot of docs like this view for injections because it's safer than the anterior, lateral, or medial approach. There's less landmines here, and I'll show you what I mean. So what you want to start with, again, patients in supine here, the elbow's at 90 degrees, but the important thing here is now, if you can see where my hand is that you rotate that hand all the way into pronation, okay? So if this is my supination, this is going to be my pronation. You're going to move that arm all the way over into pronation. What that does is it moves the radial head and exposes the distal end of the biceps brachii. Let me show you on the video here. So as we move here, you can see the radius is down here and the ulna is over here. And here's a clearer picture. This is a better picture here. So what you see here is the radius down here. The ulna is right here. And you're going to see this space right in here as Colin pronates and supinates the wrist. So as he rotates it back and forth here, you can see this parrot's beak appear right through here. Okay, that is the distal enthesis. That's the enthesis of the biceps brachii on the radial tuberosity. Now again, this is a great area for interventional purposes because you can see right in here, if you put this arm right up onto the body and you have your probe right in this direction here, well, it's just easy access. And you can see all you would need to do is bring the needle from left to right, and you could drop it right into this space right into here, and that will communicate with the tendon down the line. So again, this is a good view for that distal enthesis, and some interventional doctors like to use this view for injections into the distal tendon. So we'll go through the rest of that, but you can see where Colin is showing that distal little parrot's beak, so it looks like a little triangular shape, and that's almost the space that you would want to go right into here. The radial nerve, which is one space that you'd want to watch out for, is going to be a little over into the weeds here. You would want to clear that first, but as far as major vascular regions, you're pretty safe in this area here. So what I wanted to do was demonstrate some typical pathology, because I mean, we read these books and we see all this awesome anatomy, and when we practice, on friends and family, typically, they're pretty healthy for the most part. So this is what we're going to see from a pathologic point of view. So this is the distal anterior bicep here. And what you see is that enthesis, that distal attachment site. And the first thing I notice is this cortical step right here, telling me that there's been some wear and tear to the bone here, possibly even a traumatic event. In this one here, it's tendinopathy. You can see these fibers. They don't look as consistent. So if you look at this proximal side here, those fibers look very consistent. And as you work your way down, they start to decrease in the shape and the integrity. And then as you get through here, you look and you see that there's this undersurface tear, and these fibers don't look as homogeneous or consistent. So to me, if I looked at this one here, if I didn't have a history, this almost looks as if it would be a acute on chronic type of scenario. Moving on to that posterior window here, what you can see is some undersurface fraying, and you can see a little bit of cortical breaks down into here. So again, repetitive trauma down in this area, usually indicative of tendinopathy. Here's an artist rendering of the area that we would be scanning for the common extensor. So more of the tennis elbow, that you see out here. Again, here's that proximal enthesis right through here, and your probe orientation is going to be long axis to here. Let me show you. And here's a picture of the collateral ligament, and you can see here's the radius and the ulna. Here's the RCL right through here, and there's that annular ligament right here. So you can see how it communicates right through this area. So just do me a favor when you're doing these, don't miss the annular ligament. You know, and when you're looking at them, saying, "Oh, okay, right, that's what Ryan told me to do." All right, so let's look at the video here. And very similar to a lot of the views that we did for the distal bicep, but now the probe orientation, instead of being in line with the humerus, it's going to be in line with the radius. So when we looked at the radial nerve, you can see here is the shaft of the radius and the radial head. There's the radial head, and this space right up here is the annular ligament. Here's your RC, or your radiocapitular joint space. And so that makes this space right in here, that is the capitulum, or that's the lateral epicondylar space. So this downward slope down here is going to be important to determining, am I looking at common extensor or am I looking at radiocollateral ligament? So once again, this is the annular recess, the annular ligament, and you can actually see part of the nerve coming across through here, and up into here is the common extensor tendon here. So this is a better view right here. This is that apex, or that epicondyle. So this is the epicondylar ridge right here. This is where that common extensor attaches. And so there's going to be a slide here that shows what percentages make up common extensor versus radiocollateral ligament, but it's about 50% of this slope here. So just bear that into consideration. And then you can see right through here, that ligament down on the bottom side comes up and over the radial head. So let's get some better pictures of this here. And I have some slides to kind of indicate what that is. So again, the RCL, radiocollateral ligament, can be differentiated from the common extensor tendon and the radiocollateral ligament, comprising 54% of that slope. So what that means is that radiocollateral ligament and the common extensor tendon basically share about half of this ski slope right here. Now that ski slope stops right here when it takes that turnbuckle, so it takes this little curve right here. It ends right here. So this, from the apex to about 50%, and again, that's rule of thumb. It's not always the case. Tease it out, do some contractions, do some resisted, some tests, but 50% of this slope is going to be common extensor. 50% of this slope is going to be more of your radiocollateral ligament right here. The nice little pictures that we put in there with some arrows. And this one looks like it has maybe a small cleft in here, but I wouldn't know without testing it. And then over here, what you can see is part of that radiocollateral ligament coming up over the radial head and attaching down through here. Well, it wouldn't be a slideshow without some pathology. So here's some common extensor tendon pathology. What we have, and it's a little grainy on this picture here, but what we have here is you can see the radial head, and you can see the distal end of the capitulum, or the humerus here. This is the RC, or radiocapitular joint. And what you see is these muscular fibers turning into tendons. So this is the myotendinous junction. You can see those fibers. They look like guitar strings. They look like, you know, these sinuated fibers that come down in here, parallel in line here. And then as they get more and more towards that attachment site on the humerus here, you'll see that you lose the texture. It gets much, much thicker. And you have these small hypoechoic spaces in here. Now remember, hypo, dark, hyper, bright. Now I know a lot of people watching this right now probably know these terms. Maybe there's a couple people that don't know those terms. So let me just say that real quickly. So hyper, bright, hypo, dark, and then homogeneous is consistent, and heterogeneous looks irregular. So homogeneous fibers, heterogeneous fibers, hypoechoic cleft, hyperechoic fascial plane. Okay. Hopefully that helps out. So here's some typical things that you see with tendinopathy. Now this does not just mean in the elbow. This means tendinopathy in the body. So save this slide for later, right? So you're going to see tendon thickening, overuse. It gets thicker and thicker over time. You get those small intrasubstance tears, not these big clefts, not these big holes that comprise of massive ruptures. No, small interdispersed tears and holes throughout. Diffuse heterogeneity. So what does that mean? That means heterogeneous, right? So we talked about that. It just doesn't look consistent, right? And if I can paraphrase Dr. Joel Sellers, he would point at the wall and he would say, look at this wall. It has texture, but it's consistent texture. Now, if we go and scuff that wall up and put marks on it, well, now it is no longer consistent. It went from homogeneous to heterogeneous. So just think of that as your diffuse heterogeneity. And so the last one is hypoechogenicity, so those small little interdispersed spaces, and that realistically, they look like small tears. What is the value of using MSK ultrasound in the lateral elbow? Well, it can be used if you look at these tears and if you look at these spaces, it can help you determine whether or not you can help that patient non-operatively, or if you can help that patient with conservative physical therapy, or even if you can help that patient with orthobiologic regenerative type medicines in a clinic. Again, less invasive than surgery. You can utilize these views and these acoustic windows and this criteria on tendinopathy versus tears as your criteria on, hey, we can keep this person in-house for the things that we do, or if you're a surgeon and you're using ultrasound, hey, this is a good example of, hey, this probably needs to go under. So it has great prognostic value and diagnostic value. And again, I wrote here, patients with large intersubsist tears, less likely to respond to non-operative treatment. So again, if you have these massive tears and you put them through physical therapy, how are they going to do? Well, from experience, we know that, and also from literature now, that they don't have as good of prognosis. So now let's look at the radial collateral ligament tears. Oh no, it's not going to show up. So I have another picture of it. So right in here. So what you can see is in this area here, you can see small diffuse tears at that distal end, right in here. So this is going to be tears of the common extensor tendon and possibly some small tears of the radial collateral ligament here. So this would be, again, a chronic injury with maybe an acute, some sort of traumatic event that happened on top of it. It's very common in our clinics that we have somebody that said, yeah, I've had elbow pain before, it's probably been going on for a long time, and then one moment, they had a snap pop and now they're in the clinic. Here's a good picture of another one that we looked at before. So this is, again, that tendinopathy. This is the cortical space here, the decrease in heterogeneity. This is the fibrous pattern. It's thickened, it looks irregular, and there's those small hypoechoic clefts in there. This is a tear of the common extensor right here. So radial head, here's the capitular space right here. So this is the epicondyle. You can see right into here, this is separated from the actual bone, and it was tested with dynamic evaluation of wrist extension, and you saw it kind of pull away and retract. And you see an active inflammation response here. Now, I don't know if other presenters have explained this or not, but using Doppler is not just for vascularity. Doppler, by nature, from a physics point of view, only cares about motion, right? And you can use power versus color to determine direction of flow. Well, what we care in this instance is you can use that flow or that motion to detect whether or not there's inflammatory or even any type of, inflammation or even disease processes in here. And you can use this and it'll have a speckling effect. So not that constant flow that you would see from arterial spaces, but you'll see that speckling. And that would be a good indicator that there's active inflammation there. Here's an RCL and common extensor tear. You can see right off the bone here, it's retracted. This was in one of the clinics that Colin was in. They detected this one. I believe this one was operative and had great results. Here's radial collateral ligament. So you can see that undersurface. So remembering that rule that I said, that 50% slope down to here. Here's your common extensor tendon right through here, and this downward space right through here, and this hole right over the top here. You can actually see this portion of the radial collateral ligament and this portion. So this is your proximal and your distal portion. They're missing. right in here. And you can do a varus valgus stress test, so you can take that elbow and mobilize it to see how much motion you're getting in here. And that's a classic picture of a radial collateral tear. And this one did go in for surgery. Moving on to the medial elbow, some of the big structures of interest here are going to be obviously the UCL. The anterior band is the most common one to look at, what they call like the Tommy John repairs there. And then we're also going to look at the common flexor tendon. So opposite of the common extensor tendon, we have the common flexor tendon. The pronator teres comes over here as well, but we're going to focus our efforts on the common flexor and the UCL, or the ulnar collateral ligament. So the anterior band. So let's go to the video here. And what you can see is Colin has the probe here in line with the ulna. Now, I think that's important to note, because to differentiate the fibers of the UCL versus the common flexor is a small motion of that distal end of the probe. And when we get into the video, the live video scan that I'm going to do, I'll kind of show you how to tease those two out. But remembering the UCL, the anterior band of the UCL, goes in line with the ulna, whereas the common flexor is slightly oblique, coming from that carpal space up and over. I'll show you what I mean here when we get to the live scan. So moving the probe, Colin is sweeping it here, almost from an anterior to posterior, right over that epicondylar ridge. And what we're looking for, let me get a good view here. There we go. What we're looking for is this picture right in through here. What we see is this medial epicondyle, and it dives down and almost creates this, what they call the ladle or the spoon figure right here. So it almost looks like a little spoon down into here. So this is the epicondylar ridge. And what you see are these fibers that come from this ridge here, and I'll clean up the picture here. And it comes up and over this space. So this is your medial joint line. This is the distal humerus, and this would be the ulna. So this is not a big joint space similar that we saw onto the radial side, but that's why we're going to do some stress testing of it. So moving this on, let's see if we get it cleaned up here a little bit. There we go. Now, this triangular shape that you see right across here is the UCL. It comes across the joint line to the ulna to this little space called the sublime tubercle. And we can use the same area that you see Colin in right here with the participant right here. You put your hand on the distal wrist here and push down, and you're going to stress test that space. And let's see, he's going to be doing that right, maybe right in here. So you just put your hand right into here, and all you need to do is push down a little bit, and what you'll see is you'll see the space gap. If there's pathology, you know, you're looking for a stable joint. I remember one time I did some work with a baseball team, and they were doing this big study on UCL tears pre, mid, and post season. And what you would notice is most of your professional baseball pitchers, this didn't look normal anyway. So that's why you got this pre-picture to say, all right, this was their normal. What did it look like at the end of the season, or if they had an injury? So what you're doing is just stressing this area and getting this to gap right here if it's going to. So now let's look at the common flexor. So again, you can see patients here in supine or sideline works, take stress off the shoulder and the joint. And you can see right into here that distal probe is going to point a little bit towards the carpal row. You can see the anterior band over here of that radial or that ulnar collateral ligament, and just superficial to that, you'll see this big muscle right here as the common flexor. Right in there. So there's the enthesis, that's the attachment site right there. And you can see it goes off into this area here. And they're really easy to test. I mean, all you do is while you have the probe on, you can have them flex that wrist and you'll see the contractile space right over here. Here's a great picture of how to identify everything. So medial epicondyle, here's that ladle of the trochlea right here. The anterior ulnar collateral ligament, that triangular shape as it comes up over that coronoid space into the sublime tubercle. And here's your joint space right in here that you would be gapping. There's the attachment site right there. All right, so again, here's the pathology. So that ladle doesn't look as smooth here. So that's one of your first indicators that there's some repetitive trauma down through here. And look at that common flexor right through here. Remember our criteria for diagnostics. So we have the thickening, the decreased fibrillar patterns, and we have that heterogeneous appearance, or those small dispersed hypoechoic clefts through here. So we got that thickening, that decreased pattern. See the pattern here changes and it's very dispersed, and those small interdispersed hypoechoic clefts. Abnormal UCL. So you can see through here, through the subline tubercle looks normal, but as you go over the joint space here, what you notice is you have this hypoechoic cleft as it comes up and over, and you see a clear cortical step right here. So this, I think, ended up doing conservative treatment, but I think ultimately had surgery. See, as we're gapping it here, this is a great picture here. So I'm gonna loop this here real quick. So this is when we had the patient on the side, and you're pushing on the distal forearm. Watch this space from the distal trochlear space to the ulna here. Just watch carefully as it opens and closes. And not only does that open and close, you can also see some of these clefts kind of separate a little bit too. So now we're getting into the posterior elbow. This is our final area that we're going to be looking at today. We'll start it in long axis. And the big thing that we're going to be looking at here is the triceps tendon. So literature states that if you're going to get a tear of the triceps tendon, unless it's complete, like full thickness complete tear, typically what you're going to see is the superficial fibers delaminate a little bit, and sometimes with osteophytic fragments or what they call avulsions may come off from that superficial range. So if it's not a complete tear and you do suspect some fraying off there, it's usually going to be more of the superficial layers of the triceps tendon. And so what I mean by that, and we'll show you here, is patient positioning very easily can be viewed in supine. Elbow at 90 degrees, but put the elbow on top of the body. So now you can get to that posterior angle. You can see the probe is in long axis, so it's going to follow the tricep to the olecranon process. Now let's take a look on the scan here. So first thing you notice is the distal humerus right through here. And you're going to get that fossa right through here. So there's going to be a little fat pad round in here, and this is where your joint space is going to start. Let's see if we can clean that picture up a little bit here. There we go. So right down into here, there's that little fossa down into here, and you can see the fibers of the tricep turning into tendon right through here. And at this space, there's a healthy tendon as it goes to the enthesis. But the big things you want to look at here, here's your joint space. This can fill with some synovial fluid. This can fill with effusion down in here. It's a good area to look for any type of osteoarthritic effusion. But what we're looking at today is going to be that tricep tendon here. Okay, and there's that distal end right here. So let me clean that picture up a little bit for y'all. There we go, right in here. So here's that distal end. We're missing a little bit of this right here, but what happens with the olecranon is it takes a dive over here, and you really need to toe in your probe pretty dramatically. And what I mean by that is taking that probe, and instead of being flat and plain with the olecranon, you're really going to have to push onto the front end of it to get these fibers to show up a little clearer. Remember, one of the goals that we're doing here is tear or no tear, right? If somebody sent me this picture here, I would say, I have no idea. That could be a tear, probably not, but that could be a tear. Prove it to me that it's not. So your angles of incident are really important in this area here. Don't call something that's not there, or don't miss something. Now we're going to look at in short axis. Someone once told me one view is no view. So now we're looking at the distal humerus here. We can see the tricep muscle here. And again, that's in short axis. So it's actually looking at us at this point in time. And you can see right here, Colin has the probe almost at the distal end, but he's going to sweep it down towards the olecranon fossa. As we sweep it down to the olecranon fossa, the humerus is going to disappear into that little recess, that little fossa here. So watch as it disappears right in there. So now you can see that fat space down into here, and you can see the fossa, and you can see the tricep right before it goes into the olecranon. So here is the humerus here, and you can see the two nodules of that. As we move a little bit further distal, that will disappear, and you get this high riding little area here. This is going to be the olecranon fossa in short axis. You can see on his probe, he's gone pretty far distal. And what you're looking for here is the bony architecture here and this small tissue right on top. And that's a healthy triceps tendon right through here. And so this is the short axis view of your triceps seen down here in this area in this view. Some of the pathologies that you'll see here, obviously, are going to be tendinopathy, avulsion fractures. You're going to see effusion from the joint space. One thing that we've seen quite a few times is Olecranon Bursitis. So this whole space will fill up with fluid here. It's one of the more common areas for infections. So use your Doppler, so inflammatory and infection responses. You can't prove which one it is until you send those out, but it'll give you a good idea that something's going on in there. So as I said, it's more of a simplistic PowerPoint. So there's a lot more things that we could look at here. There's a lot more details that we could get into more advanced scanning. We could look for subluxing, ulnar nerves, things like that. But for today's lecture, I wanted to keep it simple to those 8 simple structures. I want everybody to kind of understand what we're doing with this. And then that way, when I do a live scan, we can take those ideas and transpose them onto a live scan here. So what I'm going to do now is I'm actually going to unshare my screen here for a second. I'm going to hit mute on here. I'm going to move my camera around a little bit, and I'm going to get Tim up on the table. So bear with me for about a minute. Go get a drink, go to the bathroom. This is your intermission real quick, and I'll be right back. All right, everybody, I'm back. Hopefully everybody else is back and stuck around with us. So this view here, I have my camera so you can see Tim's arm here. So most of the views that we're going to be looking at are going to be on the lateral, anterior, and posterior aspect. Once we look at the medial aspect, I'll have Tim roll on his side, and we'll look on that medial side here. So we're going to start our scans on that anterior window as we talked about before. Now I'm going to cut the lights here, and let's make sure that we can all still see what we're trying to see. All right. So I have 2 cameras going here. If there's any issues on visualization of my ultrasound screen, please, Frank, Mark, somebody let me know if something's not coming up clearly. Last thing I want to do is have anybody not seeing what I'm doing here. This is the fun part. So, and everybody, this is Tim. He's here. He's our director of this clinic here, and he's doing this program here. So he volunteered his body for me. Thank you, Tim.
You guys are welcome.
All right. So the things you'll need. Number 1, you need an ultrasound machine. Ask Frank for one. Number 2, you need gel. Number 3, you need a patient. Let's start with those, okay? All right. So from this point here, I want everybody to be able to see where my probe is here. So I tend to throw this over the top of my neck here. It makes me look cooler, but it also keeps the probe out of my face. So I'm going to show you guys 2 camera views here. And let me know how things look, okay? So here's camera 1. Here's camera 2. So hopefully that's coming out okay. Looks a little bright to me, but I don't know what it looks like on your screens. But let's start with patient orientation here and positioning. So again, I have the patient neutral, arms right next to the body, and I have the probe in short access to the humerus here. Okay, and I'm going to sweep down through this area here, and I'm going to look for that triangle that we talked about, starting at the apex of the biceps brachii over to the brachial radialis and the pronator teres, knowing that the brachialis is right smack in the middle. All right, now let's get this going. All right, so everybody can see this. Hopefully it's not too bright. Let me turn some stuff down here and see if we can get it to. There, I'm liking that a little better. Hopefully everybody's seeing that clearly. I know these cameras on these computers aren't always the greatest, but what we see here is that distal biceps here. And so let me see if y'all can see what I'm seeing here. All right. So up into here, we have that distal bicep and the brachialis down here. As we come down, remember, we're going to look for that cartilaginous space. And it looks, let's supinate that arm here real quick, like right in here. So once you see this supinated area, you can see that cartilage right through here, the hyaline cartilage, right up onto the top. Let me make sure that my finger's not in the way here. This is the biceps brachii. We move over medial. You see that big brachial artery right here. When in doubt, throw a little color on it. And it's not lying. That is great Doppler. Thank you, Frank. Now, from here onto that medial side, you can see that pronator, and I can pronate the arm here. So this is your pronator right through here. There is your median nerve just adjacent to the artery. And as we go back over, again, the brachialis in the middle. And over here on this side, we have the radial nerve and the brachioradialis. So that completes our triangle, but always find our hyaline cartilage to start. I'm going to try and turn this light down a little bit, see if we can see a little better. Hopefully that's a little better. Okay. Now, from here, I'm going to give you two different windows of the biceps. The anterior one, I'm going to skip for right now, but since I have him here, what I'm going to do is I'm going to have him put his arm in this cross position here in 90 degrees. Now, remembering what I said was follow the bicep, right? So follow the bicep down to the radius, and you'll have a much easier time finding that bicep window. So again, for this one is going to be your lateral window. So again, I'm right here, following the bicep down. All right. So from here, I'm looking for the radius, which is this circular component right through here. As you can see, off into the distance here, those are our fibers of the biceps right in there. There's a good picture of it. Hopefully you guys see this as well as I do. It's hard to tell sometimes what you guys are seeing and what I'm seeing. And there it goes right under the radius here. Now I could have my patient pronate and supinate, nice and easy. And you'll watch that tissue. There it is. You'll see it rotate back and forth. One more time for me. There you go. So I'm going to see if I can tone this down a little bit. Okay, here's your biceps brachii, that distal middle third right in here, right through the radius. This is your scan. This is your view right in here, following this proximal up until it turns to a muscle. So here's the muscle. It comes down, turns into a tendon right there. And it looks a little bright on my screen here. Hopefully it's not too bright on yours. Right to the radius. Again, right to that radial head. And then if you look carefully, you can see the two supinator heads right on top. So go ahead and pronate and supinate, and you'll see those supinator heads move across and that radial nerve right in between it. And just deep to all that, that is your biceps brachii. While he's here, might as well look at the posterior window. Again, so if I'm right here, all I need to do is rotate his wrist into pronation and move my probe over ever so slightly. So again, lateral view, posterior window. They're that close. So what I'm going to do is I'm going to get a little bit more gel here, and I'm going to show you on the screen what that looks like. So again, here's that lateral window. All I'm going to do is I'm going to rotate outward and pronate his arm. And what we should see on the screen here is what we saw on the lecture. So when looking here, what you see right here, that is the ulna. This is the radial head or the radial tuberosity right here. And what we're looking for, and try and pronate that as far as you can towards me. Well, and I would have probably a little talk with our subject here about the integrity of his tendon, but since we're just doing a simple scan here, there it is right there. So you can see, I'm going to hit freeze. You can see that peak right through here. Here's the ulna and the radius, and there's that little parrot's beak of that distal bicep right there. Once again, do that for me as far as you can. right in there. And so again, this could be a nice window of opportunity for injections right on that little space right there. So again, you could come from, I guess it would, from here, you would come from this angle and come down into that tendon. While we're here, and since he's having so much fun here, what we're going to do is now we're going to go into the lateral component, or the common extensor, and the lateral collateral, or the radial collateral ligament. Now, again, all these are happening right in the same area. So it makes you wonder, if there's pathology there, this is how you can differentiate it. Is one, your special testing, your history, they often make sense. And then finally, your imaging should help correspond or help confirm or deny what your original suspicions were. So since we're already here, let's go ahead and start looking at that lateral collateral and the common extensor tendon. So in this position here, again, we're just going to find the radius, the radial shaft, and the radial head, right? So you can see where my probe is. So you can palpate the epicondyle pretty easy, and usually your patients, if they have pain there, they'll let you know right there in that 1/3 area right in here. So I'm just going to put my probe on here, and I'm going to look for the shaft of the radius. So as you see on the screen here, we see the shaft of the radius is this bright white line right here. As we work our way proximal, you can see the radial head come into screen here. The next thing you see, and let me get some depth out of there. There we go. By the way, the depth control on this machine is pretty awesome. All right, so you have your annular recess, which is this little space here. Here's your radial head and your annular ligament right on top. That's actually really good. Right in here, that's your annular ligament right here. We move across a little bit. That's your radial capitular joint right in here. That's the radial capitular joint. And as we move across a little bit further, now what we have is the common extensor tendon, the RCL, and we have that distal humerus right here, or the capitular space right through here. What we're looking for in this area, obviously, is going to be any tears. We're looking for any type of enthesophytes. Now, if Tim doesn't mind, I'm going to show everybody what an enthesophyte looks like. So this little space right above here, right on that most apex of the epicondylar ridge, there's this small little enthesophyte, or a tiny little bone spur. It's incidental. It's nothing to go barking about, but it's there. And then with these, what you can have them do, so if you can see the screen over here, if you want to do some resisted testing or some dynamic testing, it's just a matter of the wrist right into here. So you can say, can you move your wrist up and down for me nice and slowly? So up and down. Or if you're concerned of a rupture or a tear, the next thing you could do is you could have them hold that extension and say, all right, do not move. And I'm going to push into you. Resist that, resist that, resist that. And on the screen, what you'll be seeing is right on that junction right here. Go ahead and push, push, push. You can see these fibers contract and relax. One more time, sir. Right in there. And right there, you can determine whether or not there's any delamination, any tears, or anything else going on in here. While we're here, we're in the same exact space. We're going to look at that humeral shaft, right? There's that humeral shaft. And what I want to show you all is this picture right here. So again, we have that radial shaft, I should say, not humeral, radial shaft right here. Right up in here, we have that more common area of the radial nerve. And then as it bifurcates, you can see one strand down here, one strand up here. That's going to be your PIN, your posterior interosseous nerve. And this one right here is going to be that superficial radial nerve. Again, sensory versus motor. Well, if you suspect any type of entrapment there, well, all you have to do is find that area, and then you can have them supinate and pronate. And I'm going to show you what that looks like on the screen here. Can you slowly pronate and supinate? And what you'll see is those two supinator heads contract with that nerve right in between. So if there's any entrapment there, one, you'll probably get a positive test and they'll feel that. And two, you'll see the nerve compress right through this area here. And that would be more of your supinator syndrome. Now, moving on, since we're already in this position here, it's really easy to look at the posterior olecranon or the tricep here. So all we have to do is basically just say, can you put your arm right here for me? And look at that. I can see everything I need to right here. So let's start in that long axis view like I did in the presentation. Now I know these are a little mixed up and I didn't go to the medial side yet, but I'm saving that one because I'm going to turn him to the side to show you some of the medial structures. But while I'm here, I can easily look at the tricep. So right here, that's the long axis. So there's the humeral shaft, radius, humerus. I do know my anatomy. But right here, on that distal humerus, you're just going to follow that down until you see the olecranon, okay? So let me show you what that's going to look like on the screen. All right. So as we follow this down, what you're going to see is that recess. Oh, let me get some depth in here so you can see the whole thing. There we go. There's that recess that we talked about before. See that little divot down into here? There's a little fat pad, and this will fill with effusion if there's something going on in the joint. Now, as we follow that more distal, we're going to see that olecranon process. Now, right in here, you can see the joint line and the olecranon right here. And now you can see the tendon right in through here. So muscle, tendon, myotendinous junction, and this is the distal enthesis right here. Now, to get that, I really had to go up on this end here. So I was really pushing and almost leaving this proximal end off of the skin to get that. But here's the thing is I don't care if I've already cleared that more proximal end and I don't know what's going on in that distal end. I don't care if I lose that visualization on my screen. As long as I can see that distal end and finally clear without a reasonable doubt that that's not a tear, then I don't care if the rest of the screen is black as long as I get that good picture. So let's take a look. So yes, I'm really highlighting on what they call the toe, but I can see that most distal end is intact. And that's what I care about, not making a false claim on a rupture or a tear. Okay, now while we're here, we might as well just do a quick short axis view. And again, what it's going to look like is, again, just taking your probe 90 degrees, so long axis, short axis, and we're going to scan that. And I'll do it with this hand so you can see better. I'm going to scan that from proximal to distal until I see the olecranon. And so let's show you the screen here. So we have the humeral shaft right here. We have the tricep right on top. We're going to follow that down until we see that little divot. There's that recess right in there, that humeral recess, right? And that's the one that will get filled with effusion right in there. Now that's going to disappear. So this is going to kind of disappear. And what happens is it gets to that hyaline. So now you get to that cartilaginous space. That disappears. And now you get this high-riding bony structure on top. Let me hit freeze. So now you have that bony structure on top. That's the olecranon process. And this cylindrical shape right on top. And I wish that looks really, let me see if I can. Looks pretty bright on my slab. Actually, it looks pretty good on here. But the cylindrical shape right up here is the tricep tendon as it attaches to the Olecranon Fossa here, or the Olecranon process right here. Now, since we've gone through most of those areas on this side while it's supine, again, you can do a majority of all your scans right here in this supine position. The only other position that I tend to use is sideline, having the patient face me. Now, here's the thing is, if I have my patient bring their arm here, and I have them, let's see if I can bring this back a little bit so we can see a little better. There we go. So if I have them here and they're on their back, well, that's a lot of pressure on the elbow. And if they have any shoulder issues, that's probably going to give them some shoulder issues too. So I just have them lay towards me ever so slightly. So Tim, if you can just lay on your side just a little bit here. Perfect. And what you can see here is now I'm going to be looking at the elbow for the medial side and the medial structures. Now, what I like to do is I'm going to be looking at the UCL. I like to keep my probe in line with the ulna. Okay, as I said before in the lecture, I want it in line with the ulna. Now, if I'm looking for the common flexor tendon, I know that they don't come right off of the ulna. Not all the common flexors, right? They come from more midline of the carpals, right? And they come across almost at an oblique angle. So I don't know if you can see this small little minute motion in line with the ulna, slightly oblique. In line with the ulna is going to give me a great picture of the anterior UCL. But as I take that distal end and move it ever so slightly towards the wrist, now I'm going to get an excellent picture of the common flexor tendon. So depending on what you're looking for, you might just have to make small adjustments, small tweaks to your scan, okay? So from here, again, I'm in line with this ulna. One thing I also like is the elbow is not at 90 degrees per se. It's not at 0. I just put it into a comfortable position right in between. And so what I'm going to do here is I'm going to get some gel, put it on my probe, and I'm going to find the olecranon, and then I'm going to move over to the medial epicondyle. I'm going to place my probe on here, right in line with the ulna. Now, what you're going to see on the screen here is, let's move on over. There we go. What you're going to see here, and unfortunately, and I don't know the full history of his UCL, maybe we'll ask him, but I would say he's had some work done here. So anyway, let's go to our presentation and see what we see. So here's the medial epicondyle. Here's that slope as it comes down, right? And so along this ridge here is that triangular shape of the UCL. The UCL comes up and over, remember off that trochlear spoon, remember that ladle we talked about. Here's the joint line right here, and here's that sublime tubercle off of the ulna right here. I'll clean that picture up here a little bit. But one thing I note is this space right in here looks a little disrupted to me. Tim, can you confirm or deny any kind of injury to your medial elbow?
I can confirm without a doubt.
Okay, so we get live pathology here, guys and gals. So it looks like we have a UCL, probably a pre-existing UCL tear right in through here. Let's follow that over to the sublime tubercle. You can see this little nodule off the top here. And we'll be nice to him. We'll do a nice and easy exam. And we're going to test for mobility. And it moves a little bit. Okay. So we do have some pre-existing pathology here. It's always not fun for him, but it's always fun for us to see not only the normal, but also the abnormal. Now I'm working on to the common flexor, which is what we're going to look at next. But remembering that UCL is that little triangular shape that comes from that downward ridge down to the sublime tubercle at the joint line. Now, once again, we're going to take that probe and we're just going to rotate it ever so slightly towards the carpal row. As we do that, let me show you what it looks like. So now we see that anterior band right here, and I'm rotating that probe. Now that's all tendinous. See this nice tendinous bundle right on top? And that's the common flexor tendon. I would also ask if he had some issues with the common flexor. I see something going on up at that distal enthesis here, right up on the top here. So anyway, Tim and I will have a long talk afterward probably, but what you're all seeing is some enthesophytic ridges or bone spurs on the distal end here. And it looks like heterogeneous, right? Remember that thickening. So this would fall into the category of a tendinopathy with a possible injury to the UCL at one point in time. Okay, and he is shaking his head. Yes, that is true. And I'm sorry to hear that, but you're in the right place. We'll get that fixed. All right, so that is that medial joint line. Again, there's a lot other things that we could do. There's a lot other scans that are available. I want to say thank you to Tim for coming in and doing the scan with me.
Thank you guys for having me.
And what I'm going to do is I'm going to bring my machine back over here. And now y'all have to see my face again. I apologize. Here you go. So that was a quick live scan. We hit the bicep tendon. We hit some of the nerve complex around that area, brachialis, brachioradialis, pronator teres, and anterior window. We looked at that lateral window of the distal bicep. We looked at the radial collateral ligament, and we also looked at the common extensor tendon. We worked our way around to the posterior angle and looked at the posterior window of the bicep tendon, as well as we looked at the triceps tendon and the fossa. Then we worked our way over to the medial side and looked at that common flexor tendon. And we also looked at the UCL. Most commonly affected is the anterior band of the UCL. So you could do a more thorough exam, but I just wanted to give you all an idea of what you can do in this kind of area, having someone in supine real quickly get most of your structures and have them sideline and seeing the rest of the structures. So I want to say thank you so much, everyone, for joining me, for joining Wisonic with this. Thank you again to Frank and Mark for introducing me and bringing me to this. And again, thank you, Tim, for being a model and having a perfect elbow and having both normal and abnormal anatomy.
My pleasure.
Ryan, we want to thank you for your great elbow presentation and the live scanning. That was the hit of it. We got a lot of comments about your scanning. They loved it. They learned a lot more than just a slideshow. So we have some questions. Do you have time to answer some of these?
Yeah, I have some time to answer these. Yes.
Perfect. Let's start here. Let's see. Hello, Dr. Martin. May I ask what the best frequency of your linear probe you recommend for elbows?
Well, elbow is most typically a superficial structure. Now, you're going to get some big elbows, but that doesn't mean you need a big probe. So the higher the frequency, obviously, the higher the resolution, but the more superficial the structures. So anything in that range from like, I don't know, anything from 11 up, 10 up, 9 up, your higher frequencies. You just don't want to be down in the ranges of the 2s, the 3s, those curvilinear frequencies. So I keep it in that mid-range, almost like a shoulder range. Like I said, anywhere from 12 range, 12, 14-ish, that kind of range.
Excellent. Next question is by Andrew. Do you feel ultrasound is gaining ground on MRI when scanning or imaging extremities?
That's not fair. I'm biased. So yeah, I think it's gaining ground in certain areas. Now, obviously, we have to look to the literature and make sure that we're doing our due diligence and doing the scans appropriately and earning the credibility that MSK Ultrasound deserves for this. But there's literature support that in certain cases, ultrasound has met and or possibly exceeded some of the MRI. And the reason I say that, and if anybody out here has done ultrasounds before, it's because of the capability of doing it live and doing dynamic evaluation. Now, you can't do that with every structure, and MRI will be superior to other things, but is it gaining ground? Yes.
Excellent. Next question here. What is your experience finding pathology with ultrasound that MRI has missed?
Oh, I'm going to get in trouble here. Usually it's the shoulder that I see some discrepancies with some small delamination tears, intrasubstance tears. Sometimes I see things that appear bigger on ultrasound and that were not seen on MRI. And then when I do a dynamic evaluation and test supraspinatus and you see it open up or possibly retract in certain areas where an MRI wouldn't have seen it, yes, that's probably where I've seen it the most. There's been other cases, but usually it's the case of missing fractures and ultrasound picked one up, incidentally, or when looking for something, they'll find like a stress fracture where an x-ray missed. But in ultrasound, I hate claiming that, but there's been some incidents where we found stuff where MRI didn't.
Sure. Next question. Do you use color Doppler to find pathology? If so, what does color tell you?
Color and power I use. I like power Doppler. It's a little bit more sensitive. Color Doppler really cares about directional flow. Again, for pathology-wise, what I'm looking for is any type of inflammation around an area, like a joint space. So if you have hyperemia or an increased blood flow to that area and that speckling that I was talking about, you could have an acute or active inflammation. So yeah, anytime that I have something that has fluid around it or swelling around it or looks irregular, I'll throw the Doppler on there and see if I'm getting any speckling on there. Or if I think that, like, say, if I see an Olecranon bursa that's distended, I'll throw it on top of there and it'll show me speckling. Now, one thing to bear into consideration is it cares about motion. It doesn't care about what it is. So if it's an infection or inflammation, the Doppler doesn't necessarily know the difference, whether it's color or Doppler, or power, I should say. So I use it all the time, but sometimes it doesn't give me all the information I want.
Sure. Next question. I would like to know, what are the benefits of using ultrasound versus MRI to scan the elbow anatomy?
Well, the biggest thing is the dynamics of it, the live time of it, and because of the high resolution and the high frequency of it, most of the elbow is superficial. Obviously, you're not going to see in the joint space, so you're going to need something else for that, right? But for all these superficial structures, the benefit of the ultrasound is unparalleled because it has such a high resolution at such a shallow depth, and that you can move it. So that's the one thing is X-ray, what do they say? Don't move. MRI, don't move. CT scan, don't move. Ultrasound, move. So the added benefit of that dynamic assessment is unparalleled. And in the hands of somebody that knows how to do it, somebody going through the training and doing it the right way, it's a no-brainer. And again, it shouldn't replace anything. Like what people get nervous about, or what they talk about, is that this is going to be the next MRI, or this is the next stethoscope, or whatever they keep calling it. But realistically, it's just another tool that's going to help identify what you need to. And it can be in the timely space and time that you need to at that time. But it should never replace anything necessarily, not as a whole, but there's going to be some things down the road that more literature is going to support advancements in ultrasound scanning.
Very true. Last question here. What is the best way to visualize the ulnar collateral ligament clearly? So the best way to see the ulnar collateral ligament clearly is with that patient laying on their side. Let me grab my probe. Laying on the side, putting that probe in line with the ulna. So that's the anterior band. So that's in line with the ulna right here. And so while they're laying down, in line with the ulna is going to be your best visualization of the ligament, because it's actually connecting from the humerus to the ulna. So that in line here. Again, as you rotate, you're going to lose it a little bit. So that's the best method right there. And the best positioning, in my opinion, is sideline. Dr. Martin, greatly appreciate your time this evening. Live scanning was fabulous. We got tons of congrats on the live scanning. Presentation was awesome. Thank you again. Thank you, everybody, for joining us. And I'm going to turn it over to Frank.
Thank you, everybody.
So, Dr. Martin, on behalf of Wisonic Medical, thanks so much for your excellent presentation. It is very delicate and enlightening. Especially, I love the live scanning part. It's very wonderful. We would like to cooperate with you for more webinars or other events in the future.
Absolutely. This is what I love, you know?
Okay, that's great. Let's keep in touch. And Mark, thanks again for your efforts. And the questions you just asked helped us to know more valuable knowledge. Thanks.
You're very welcome.
So, and everyone in the broadcasting room, thank you for your watching today. I believe you must have got a lot of inspiration, and welcome to join our webinar on next Thursday again. Dr. Colin Rigney will present the fourth webinar with topic on ultrasound in MSK practice, hand and wrist. Let's stay tuned.